Now it's my pleasure to introduce our opening speaker, Dr. Lindsay Weaver. Dr. Weaver joined the Indiana State Department of Health as Chief Medical Officer on February 3, 2020. She brings to the role a passion for both emergency medicine and end-of-life care. Dr. Weaver is an assistant professor of clinical emergency medicine at the Indiana University School of Medicine and practices emergency medicine at Methodist Hospital in Indianapolis. She is board certified in both emergency medicine and hospice and palliative care medicine. She earned her undergraduate degree in biology at the University of Kentucky and graduated from the University of Louisville School of Medicine. She received residency training in emergency medicine and fellowship training in hospice and palliative medicine at Indiana University School of Medicine, and she completed a fellowship in ethics at the Charles Warren Fairbanks Center for Medical Ethics at Indiana University Health. She has served as quality director for the Department of Emergency Medicine and physician lead for the System Sepsis Steering Committee at IU Health. She also served as executive director for the Indiana Patient Preference Coalition and as president of the Indiana chapter of the American College of Emergency Medicine Physicians. Dr. Weaver and her husband have 5 daughters. Thank you so much for being here, Dr. Weaver. I'll let you take it over.
Thank you, everybody, so much for having me today, and thank you for your work to protect Hoosiers from asthma. Under the best of circumstances, asthma is a serious chronic disease that impacts almost 10% of Indiana adults and almost 7% of our children. But these are not the best of circumstances. Individuals with asthma are especially vulnerable to COVID-19. Their condition puts them at greater risk of severe illness or complications. And members of our minority populations are even more significantly impacted by asthma and have been more impacted by COVID-19 than their white peers. So the work you do to raise awareness and help protect Hoosiers is more important than ever, not just to protect Hoosiers, but to eliminate disparities in health outcomes. We are working to reduce the burden of asthma in Indiana to levels reflected in the Healthy People 2030 goals. The following are the Healthy People 2030 goals. 1, reduce hospitalizations from asthma. Objective 2, reduce emergency department visits for asthma. Objective 3, reduce asthma exacerbations. And objective 4, reduce deaths from asthma. A strategic plan to address asthma in Indiana was developed through the joint efforts of the Indiana Department of Health and the Indiana Joint Asthma Coalition. This plan establishes focus areas, objectives, and strategies that can be used by organizations, professionals, and individuals to improve the health of those living in Indiana who have asthma. It provides Hoosiers with evidence-based and comprehensive approaches to improving the health and equity of life for those with asthma, while also offering practical strategies that can be implemented and sustained thereafter. The Indiana Asthma Program, housed within the Chronic Respiratory Disease section of the Indiana Department of Health, works to reduce the burden of asthma in the state, as well as to reduce the disparities in asthma rates. By providing educational materials and learning opportunities such as the summit, the asthma program raises awareness and provides information for a variety of stakeholders, including the public, partner organizations, clinical providers, as well as in promoting environmental strategies and system-wide changes to support improvements in asthma health outcomes. Finally, I want to stress it is important for children and adults with asthma to remain current on their vaccinations and to receive an annual flu shot. Those who are eligible should receive the COVID-19 vaccine. I especially want to stress, and I've made it a personal mission of my own to talk on every opportunity I can get in front of people, the importance of COVID-19 vaccines, especially with our pregnant women. We have seen a significant rise in pregnant women requiring hospitalization, and unfortunately have had several pregnant women and their unborn children die in the recent month with the new Delta variant. Just in the last several weeks, every organization, including the CDC, the American College of OBGYN, The Society for Fetal Medicine have all come out and stated that it is imperative that women and recommended that women get the COVID-19 vaccine. I ask and I implore all of you as an emergency medicine physician who cares for these patients with asthma, who are presenting with COVID-19, to make this part of your daily conversation and part of your daily work to encourage people to go out and get vaccinated. As you all know, prevention is just as important as a treatment, and we can all do this together. I congratulate you on the work that you have already done and that you will be doing, and I hope that you guys have a great summit. Thank you again for inviting me to give these opening remarks.
Thank you, Dr. Weaver. Greatly appreciate you being here this morning. At this time, I want to introduce our keynote speaker, Dr. Nadia Krupp. Dr. Nadia Krupp is a pediatric pulmonologist and an associate professor at IU School of Medicine. Dr. Krupp has been faculty at the Indiana University School of Medicine for the past 11 years and has served as the director of the Riley Asthma Program for 9 years. She has focused her career on pediatric asthma in both treatment and education, and also in treating severe asthma at the High Risk Asthma Clinic. She has been an invited speaker on the topic of pediatric asthma throughout the state of Indiana, as well as at national and international conferences. Dr. Krupp works towards keeping children healthy and out of the hospital, allowing kids to lead full and enriching lives without limitations caused by asthma, and most importantly, to treat the whole patient and not just the asthma. Dr. Krupp is a founding member of the Indiana Joint Asthma Coalition. Thank you for being with us today, Dr. Krupp, and I will hand it over to you.
Good morning. Thanks, Courtney. I appreciate the introduction, and I'm really excited to see as many people as we have here today. It looks like we have a fairly diverse group of attendees, and hopefully we'll have more attendees who watch the recording even later. I will share my screen and we will get started. So I am going to go over and give kind of a broad overview of the state of asthma here in Indiana, so that we all kind of know what we're dealing with before we get into today's speakers. I don't have any financial disclosures or conflicts. First, I'm going to talk about the scope of asthma across the state, who's affected and who's not, some of the different disparities that we see and the challenges that we face. I'm also going to go over some of the recent advances that we have in asthma care, because we have had some significant research and improvements in the treatment options that we have for asthma, especially over the last 10 to 15 years. So I'll touch on that. I'll also introduce, for those who are not familiar, the concepts of the intersection of the medical and the non-medical and how those interplay with each other to impact asthma severity and control, and then give some thoughts about where we could potentially go from here. So to begin with, across the country, when we look at the entire nation, about 25 million people have asthma. That includes about 8-ish% of children. That number fluctuates over time a little bit, but it has stayed fairly steady around 8 to 9%. For the people who have asthma across the country, it leads to about 8 million missed days of school, which is one of the leading causes of school absence here in the US, and about 11 million missed days of work. When you look at the cost of asthma in dollars, it's a few different ways to calculate cost. One of them are the direct healthcare costs. So this is the cost of hospitalization, the cost of emergency room visits, cost of doctor's visits, medications, that kind of thing. But there's also a dollar cost that we feel as a society when people miss work and miss school, or if they end up disabled or even die of their asthma earlier than they should. When you include all of those costs together, then each year it costs the country about $82 billion. That's billion with a B. And And unfortunately, people sometimes forget that asthma still can be fatal. Unfortunately, it doesn't happen as often as certain other diseases, but it can be tragic when it does. About 10 people die each day from asthma. That's even prior to our COVID-19 pandemic. And unfortunately, some of these are children and teenagers. Each year, typically, we hear about a couple children or teenagers who have a severe enough exacerbation that they don't make it. Over here in this graphic that I have, when you're thinking about the scope of, say, school days missed, almost half of children who have asthma will miss at least one school day per year. The unfortunate part of this is that that's not very evenly distributed. And so some children will miss, say, 20 or even 30 days of school over the course of a year because of repeated exacerbations, hospitalizations, and illnesses. So while one child might miss one day or half a day, other children will be more severely affected, which then will impact their educational opportunities and performance for years to come. When we drill down to Indiana, about 9 to 10% of adults have current asthma, as Dr. Weaver just said. This rate has been fairly stable over time and just above the national average, which is closer to about 8.5 to 9%. When we look at children on a similar graph, the rates have also been fairly stable over time. The actual prevalence of asthma has not decreased despite our advances in medical care. Looking at the number of hospitalizations here in Indiana, about 500,000 people have asthma, and that leads to about 7,000 hospitalizations a year. And then when you look at those indirect impacts, say lost productivity, missed school days, about 2/3 almost of adults with asthma have missed work or had poor work performance in the last 12 months because of their disease. Asthma is not evenly distributed in its severity by race or age. As Dr. Weaver alluded to, minorities have a larger burden of asthma compared to their white peers, particularly African-American Hoosiers and those of Puerto Rican descent. Interestingly, Puerto Rican descent is a bit distinct from the general Hispanic population, which tends to be a little bit lower than their Black peers. When we look at sex, males have a higher incidence of asthma when they're young. So if you look under the age of about 8 years old, then it's going to be male predominant among children. The boys tend to, on average, get a little better and the girls don't. And so by the time you get to teenagers and adulthood, then the female prevalence takes over. Now, that's not to say that every boy who has asthma is going to improve, but as a population, they have a better chance of improving over time compared to girls. When we look at income, then the lower income population have a higher overall rate of asthma and also higher overall rates of ED visits and hospitalizations. The lower income you get, then the more pronounced this is. So if you're below the poverty level, then your chances of both having asthma and having your asthma being harder to control are both significantly elevated. Now, when we look throughout the state, this is also not evenly distributed. We have certain counties that bear a higher burden of asthma severity. This is measured in this map by emergency room visits for children, but the distribution is similar whether you look at prevalence, so the number of people with asthma or hospitalizations or emergency room visits for children or adults. The maps all look about the same with some minor differences. Now, one of the questions that we face is why this is the case. So this is pretty multifactorial. Some of it has to do with healthcare access. So whether they have access to good primary care, specialist care, do they not have access to or easy access to outpatient care, and therefore they use the emergency room primarily for their asthma care? Are they uninsured, and so they don't have a provider that they can go to reliably, and so they wait until they have more trouble and then present to the ER? Do they have higher environmental exposures or different types of environmental exposures? Some of this could be education and expectations about how we can manage asthma and what the goals of asthma care are. And then there's also wide variability in housing and housing stock, air quality, and exposures that can be found in the home or in the school or in the workplace. Asthma is a chronic disease. It's present year-round for those who have it, but it tends to exacerbate at certain times of year. The fall peak is typically the highest, and this is pretty consistent year to year. You'll see it starts to rise in August, peaks in September to October, and actually falls a little bit in December and January until it rises again starting in March through about May. There are multiple factors contributing to this as well. Some is allergens. So the spring and fall pollens. Here in Indiana, we are an agricultural state, so sometimes it's not actually allergens, it's planting and harvest that actually trigger people. They can test negative to all the allergens, but they swear that they have trouble spring and fall. And then if you ask if they live near fields, they say, oh yeah, it's when they're plowing. And so sometimes that can be a trigger as well. It's just the physical particles landing in the airway that can give them similar symptoms to what we think of as seasonal allergies and can flare their asthma too. Viral infections play a big part in this. The fall viruses that we typically see are usually rhinoenteroviruses, sometimes with some parainfluenza and others. Right now, we're having an unusual year. We did not see much of our winter viruses this past winter because of masking and distancing and a lot of our viral precautions. We are in fact seeing some of them now. So we're having our RSV season now in July and August, whereas we normally see it in say November through February. So that's adding yet another wrinkle to our current care of our respiratory patients, that we not only have to have rhinoenterovirus and COVID and asthma on our list of possibilities, but RSV too. Ozone is another trigger, particularly later in the summer when it gets hot, as the ozone levels at ground level rise, and because that's a pretty potent airway irritant. And then particulate matter. So that can be planting and harvest, as I said before, or it could be particles related to industry or traffic or combustible products, people burning trash or living near an incinerator, things like that. So when you think about all of these combined, then this is why we get this fluctuation. When we think about asthma treatment, it's changed a bit over the last, say, 50, 60 years. Before about the 1960s or so, it was thought to be an episodic disease only. It was not necessarily considered chronic because people would only have trouble intermittently, and so it was thought to be an intermittent disease. A lot of the medications available were subcutaneous and injectable medications. They did have inhaled adrenaline, which can help to open up the airways, but treatment options were fairly limited. There was a rash of asthma deaths in the 1960s.
Hi, Zach. I'm calling with a question. I was looking at the rooftop tickets for the games, the little packages that they had, the Rock the Rooftop, I think it's called.
I think somebody's not.
So when you purchase it, it gives you a section and a row of seats. Do you actually?
Okay, thank you. There was a rash of frequent asthma deaths in the 60s. And that prompted development of some more refined medications that we can use for bronchodilators. Salbutamol was the first one. Albuterol is what we tend to use here in this country, which is essentially the same medication, although salbutamol is still what they use in Europe and elsewhere around the world. The 1970s led to an increased recognition of asthma as a chronic disease, and the development of the first inhaled corticosteroid, which is beclomethasone. So this is currently known as QVAR. And in the 1990s, by then, additional inhaled steroids had been developed. We also had the introduction of long-acting bronchodilators, so not just salbutamol or albuterol. We had some longer acting agents that would last about 12 hours or so to use for asthma control day to day. After the 2000s, we had our first what we call biologic agent. So these are monoclonal antibodies that help to target the underlying inflammatory pathways of asthma. The first one was omalizumab, which is known as Xolair. That had was the only one that we had for quite a while. And then in the 2010s, we had the addition of tiotropium, which is Spiriva, which can also be used for symptom control day to day, as well as the introduction of additional monoclonal antibodies to address the underlying inflammatory pathways. So we now have a lot more medications in our toolbox that we can use for asthma to try to keep people out of the hospital, out of the emergency room, and doing well. The current approach to asthma care has a few different components to it. So number one, we have to recognize it as a chronic disease and educate our patients about it being a chronic disease so that they understand why they need to take medication every day, even though they only have trouble intermittently. Most patients who have frequent symptoms will end up benefiting from daily medication, particularly those who have ended up in the hospital or the emergency room to prevent those severe outcomes. Allergy testing is frequently included and is recommended as part of the full evaluation for a patient with asthma, so that you can identify triggers for these asthma symptoms and that therefore have a better idea of how to control or avoid them. Education is focused on disease self-management, how to treat exacerbations at home rather than having to present to the emergency room, and to get back to your daily activities as quickly as possible. We do have national and international guidelines regarding asthma treatment that are aimed at standardizing provider knowledge so that everybody's on the same page with what is available and what's recommended, to use our evidence-based practices to preferentially use proven medication treatments with known strategies that work the best for a particular population, how to optimize use of controller medications. So this is aimed at how to educate your patients so that they know how to use their medications correctly, when to use them, and what the role of those medications are. And then home environmental assessments where at all possible. So somebody who is trained who can actually go into the home and look around and help that family identify what is in their house that could be making their asthma worse, and then how to potentially remediate that. Now, even with these guidelines and more providers around the country being knowledgeable about asthma and aiming to use these guidelines as much as possible, the use of controller medications is pretty variable. So when you look at the country across the board, the use of daily controller medications is can vary anywhere from about 30% to close to 50%. Now, these are not necessarily patients who the controller has been prescribed and whether they're using it or not. It's just across the board those with asthma. So some of these patients may not necessarily have been prescribed or need controller medications, but chances are things are not that different, say, in Ohio compared to Indiana. or that different compared when you look at, say, Nevada to Arizona. And so the fact that there's this much variability has a lot to do with uptake from both the provider and the patient side of these recommendations. And despite the fact that a decent number of patients have long-term controllers that they use, a lot of patients still struggle to gain control of their asthma. So now we're going to talk about a few of the things that can make asthma difficult to control. So in order to do that, we have to take a little bit of a step back and think about what affects health in general. So when we think about medical factors versus non-medical factors only really account for about 50% of our health outcomes. So this is health behaviors and clinical care, things like tobacco use, access to care, quality of care, medications. Those can impact our health outcomes, but they don't get us all the way there by themselves. Societal and environmental factors are equally important and can be harder to modify. So things like income, community safety, family and social support, air and water quality, housing, transit, all of those kinds of factors that can impact our overall health. Asthma is particularly susceptible to environmental factors, as we talked about already. So air quality, allergen exposures, those can directly affect the disease. And so that's why for asthma in particular, it's important to look at the whole patient and the context in which that patient lives in order to better affect their asthma outcomes. So we have some opportunities in asthma care. We have some opportunities to personalize and tailor asthma treatment. Most medications that we have target allergic and eosinophilic asthma. So eosinophils are a particular type of immune cell that affects a particular immune pathway. But there are other types of inflammation involved in asthma that are not ideally addressed by the medications that we already have. This is an active area of research, but there's still a lot of work to do to figure out what these medications are and how to best use them for which patients and how to best identify which medications are going to work the best for which individual. Some resources for environmental remediation are important. There's currently quite variable access to this around the state and around the country. So this can vary anywhere from having absolutely no access to environmental remediation or education about it, all the way to having a robust system in certain areas of the country where there are trained individuals who can go in and identify issues, but also have resources where they can pull in somebody who can remediate those problems for the family. If these programs have financial funding, then there are some that can do this at no cost to the family or at nominal cost to the family and improve their living conditions. Insurance and financial resources are an issue for a lot of our families. That we continue to advocate for stable insurance access and pharmacy access for patients around the state. Medication costs are quite high. And especially with inhaler medications, they can run anywhere, for the controller medications, they can run anywhere from $80 to $400 a month for a single inhaler. And if you're taking multiple inhalers per month, that adds up awful quickly. If your insurance doesn't necessarily cover those very well, or you have a high deductible, high out-of-pocket costs, then that can be a huge financial burden for families. Then if you have multiple people in the family who have asthma and you're paying for these medications for not one, but 4 people, you can see how that adds up rather quickly. There are not generics available for most of our asthma inhaler medications. There are for a couple of them, but they still end up being fairly pricey. And because they are in an inhaler form and not in a pill form. You can't necessarily divide up an inhaler to send one to mom's house, one to dad's house, and one to school. You actually have to get multiple inhalers and leave those in those places, which is different than if you had, say, pills or liquid that you can more easily distribute amongst the people who need them. We also have some opportunities to change healthcare culture. Historically, in this country, we've had more of an emphasis on how we deliver sick care. So how we take care of people when they're in the hospital or in the emergency room. How do we then make them better and get them home? And as a nation, overall, we're pretty good at this. A lot of research has gone into new treatments and technology and medications and those types of things for these critically ill patients. And we are pretty good at getting them well when they are sick. We are not as good as a nation and as a culture on focusing on wellness and prevention as we could be. There are other models of care around the country or around the world who have more of a focus on wellness and prevention and less of a focus on sick care. There's no perfect healthcare system anywhere in the world, but if we want to try to improve asthma outcomes for the long term, then we do need to pay a bit more attention to wellness and prevention than we have before. Ultimately, of course, the goal is to find a cure for existing asthma, where once asthma develops, then we can intervene and then resolve that inflammation and airway sensitivity so that it does not come back again. And then even beyond that, being able to prevent asthma from occurring in the first place is ideal. Now, whether we get there or not is debatable, but it's an active area of research for a lot of people around the country and around the world for how to get closer to these goals. Because asthma is as complex as it is, we do need input from all sectors. And so we need input from patients about what they're actually experiencing, where their challenges are, what they feel and what they're able to do, what they're not able to do, what's reasonable, and what are the various barriers they have to achieving their asthma control. Families and caregivers often have a different perspective than patients, especially in the pediatric population. So getting input from the people who care for our patients directly is critically important as well. Input from healthcare providers could be which medications seem to be working better than others. There's research on this, as I said before, and where they see their patients struggling with asthma care. We can get a lot of information from our providers around the state. Environmental experts are critically important to addressing asthma. The exposures not only in the outdoor setting, so outdoor air quality, car exhaust, power plants, particulate matter, those kind of things. Those are very important, but also indoor air quality. So anywhere that an asthma patient goes and spends significant time indoors can affect their asthma. So this could be indoor smoking, so say at a parent's house or at a grandparent's house or in a car. It could be mold or pests or inadequate ventilation. There are multiple things that our environmental experts can weigh in on and help us to figure out how to best support communities in making these better. Community advocates could be from any discipline. It could be patients, social workers, teachers, physicians, nurses, respiratory therapists, EMTs, you take your pick. But anybody in the community who sees people struggling with asthma and wants to help make that better can advocate within their local community or at the state level for what they are seeing. And then from a larger perspective, those who make policy in the state, we need input from them. So that could be policy at the level of schools or counties, cities, or state government. They could, those people who have the decision-making power around the state are also critically important to making headway on asthma control. And then from an industry standpoint, pharmaceutical development, new treatments, those are going to be important moving forward as we try to have more tailored approaches to asthma care as time goes on. I'm going to touch just a little bit on COVID-19 and some of the asthma-related challenges that we are currently seeing and we anticipate seeing. So COVID has been obviously a challenge for everybody and in almost every way that we can think of. There are some additional challenges that we face in caring for our asthma patients. So initially we felt that maybe it would have an increased risk for asthma patients compared to those who do not have asthma. This is looking more and more likely, particularly with the Delta variant, as Dr. Weaver was saying earlier. This does seem to vary a little bit between children and adults. And it also seems to vary based on risk and what medications they're on. And so we counsel our asthma patients that they are likely at increased risk from severe complications from COVID-19. I've even been counseling the children and the teenagers on this. And it's as precaution if you are eligible to be vaccinated or there are others in your household that are eligible to be vaccinated, it's particularly important for that population to protect that patient as much as possible. One of the other challenges that we have is in symptom overlap. And so COVID obviously is characterized by coughing, shortness of breath, often congestion, sometimes sore throat. And a lot of those symptoms can be seen in an asthma exacerbation as well. And so being able to distinguish for patients and for schools and for parents, whether something is asthma or is a COVID-19 infection has been difficult. Primarily, this is important for quarantine reasons and to determine when that person is safe to resume their new normal activities, to go back to school or go back to work. It doesn't, sometimes it changes what we do for medications, but a lot of times it's more for mitigation and to try to reduce the spread of COVID-19 is the primary goal. We get a lot of questions about masking. We get a lot of questions about whether it's safe for a child with asthma to wear a mask, and the answer is yes. We get a lot of questions about potential exposures and whether the child should go to school or not, whether it's safer to keep them at home. We had those from the beginning of the pandemic, and we're getting more of them now as the Delta variant spreads more. Those questions are difficult to answer, honestly. The masking one is not, especially now with new CDC guidance about everybody, regardless of vaccination status, should be wearing masks indoors. That one's easier to answer. The exposure questions are more difficult. A lot of those answers end up relying on what is in place in that school to try to minimize spread. And so if the school is masking and they're distancing and they're contact tracing and quarantining, your risk goes down. If they're doing none of those things, then your risk is obviously higher. And that's a parental decision about if it's feasible to try to provide education for that child in the home setting. So we talk about the relative risks and benefits, and then ultimately it's up to the parent, but we try to provide as much guidance as possible. Healthcare access is a huge challenge, particularly right now. Emergency room emergency rooms are overflowing. Hospitals are pretty full. Primary care offices are pretty full, partly because a lot of schools, most schools, are requiring either an alternate diagnosis other than COVID or a COVID test. And so they need a note from a doctor saying that this child's runny nose is not COVID before the child can go back to school. Whereas in the past, that child would have a runny nose, and unless they were febrile or in distress, they would just stay at school. That is not the case. And so primary care offices are flooded with people who need to be seen immediately so that that child can get back to school. And so healthcare access for other types of sick visits is decreased. There's a lot of fear of exposure to illness. And so we do a lot of counseling for this, for how to keep children safe, how to keep those who are not eligible to be vaccinated safe. We've talked a lot about that with our patients over the last several weeks in particular. And then there's the financial impact that so many people and families have faced over the last year, whether it is them being scared to work because of COVID exposure and not being able to work because they don't have reliable childcare, or their kids keep being sent home to quarantine so they can't hold their job, or if they have lost a family member who is an income source. All of those things have a significant impact on a lot of families. And so then when you have the cost of inhalers, say, added to that, or the cost of getting transportation to get to the pharmacy and get to the doctor's office, those are, all of those factors can impact asthma care during this time of COVID-19. Vaccinations are critically important. We get a lot of questions about vaccinations as well, and trying to encourage as many patients and parents and siblings and friends and grandparents, everybody, to get vaccinated, not only to protect themselves, but to also protect the child who has asthma. The Delta variant is spreading rapidly, and unfortunately it coincided with the reopening of schools. A lot of the policies that schools came up with regarding masking and distancing and quarantining and virtual learning, a lot of those policies were actually developed in, say, June, because they needed time to develop and finalize them. And as we know, back in June, we were in a quite a different state than we were now. We felt like things were getting better. We hadn't necessarily seen the rise in this Delta variant yet. And so some schools have had some challenges in adjusting those policies to reflect what is happening now. And those policies that were made back when things were better are unfortunately still in place. In light of this, we keep getting more and more questions about the safety of children with asthma in school. And I counsel families that it's not just the child with asthma. If they have other children in the home, then they could potentially be at risk as well. Our instinct is to protect the child who has existing lung disease. But we have to be careful with all children, and I counsel parents that they have to make sure that they take care of themselves so that they remain healthy and alive, so that they can take care of their children for years to come. So we've had a lot of conversations about that. So in light of all of that, I welcome our speakers for today. We have a variety of topics that touch on a lot of the things that I mentioned here. We have several different perspectives from the research standpoint, from the environmental expert standpoint, from the medical standpoint, so that we can hopefully start to generate even more ideas for how we can improve asthma care here in the state. I think today and moving forward, we have an opportunity to create some more partnerships and share our expertise even more widely amongst each other, and see how we can support each other, because it takes more than a village for all of this work. So with that, I'll pass it back to Courtney and we will move forward. Thank you.
Thank you so much, Nadia. That was a really comprehensive introduction to not only asthma in Indiana, but what we can expect to hear today at the summit. So greatly appreciate you opening and also the work that you're doing with the coalition and with patients in the state of Indiana. So at this time, we have an opportunity for a quick break. So we will reconvene at 11 o'clock in about 13 minutes. I'm watching the clock change to do a quick yoga break, and then we'll get started on our breakout session. So feel free to take a comfort break, stretch, turn your camera off, turn your camera on, whatever you need to do. And we will see you at 11 o'clock. Thank you. And I will be here if you have questions, you can drop them in the chat.
Closing time. Open all the doors and let you out into the world. Closing time. Turn all of the lights on over every boy and every girl. Closing time. One last call for alcohol, so finish your whiskey or beer. Closing time. You don't have to go home, but you can't stay here. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. Closing time. Time for you to go out to the places you will be from. Closing time. This room won't be open till your brothers or your sisters come. So gather up your jackets, move it to the exits. I hope you have found a friend. Closing time. Every new beginning comes from some other beginning's end. Yeah. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. Closing time. Time for you to go out to the places you will be from. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. I know who I want to take me home. I know who I want to take me home. I know who I want to take me home. Take me home. Closing time. Every new beginning comes from some other beginning's end.
Okay, welcome back. So right now we are going to do a little bit, 5 to 6 minutes of chair yoga. So feel free to turn your camera off. Most of you have it off, or turn it on, whatever is comfortable for you. And we're going to do a quick yoga break so that we can get a little movement in and be ready to start our first breakout sessions.
Technical difficulties. Hang tight just 1 second.
No problem. It would not be a summit without a technical difficulty. right, welcome back. I hope you enjoyed the yoga break. That was Adrienne Mishler. She has a lot of free yoga videos. I'm a big fan, so hopefully a little movement was good. At this time, I want to go ahead and introduce our breakout session, One Topics. So what you will see in the chat are links for both of these. You may choose either one and view that. So coming up, we have on the public track, we have air quality and asthma, living conditions with Lisa Caldwell. And for the clinical track, we have the 2021 updates to the NHLBI and GINA guidelines with Dr. Kirsten Klepfer.